Hello, everyone. It's week number 4. I cannot believe that we're in week 4. It just seems like we started yesterday. All right, so this is week 4. This lecture is part 1 of 3 for your outpatient reimbursement and billing course. And week number 4 actually is a week where you get to do some more coding, right? Because this is a coding program. So this week you are doing chapter 6, 7, and 8 in our Understanding Health Insurance textbook. And since there are 3 chapters, there will be 3 lectures. And I think the cool thing is you kind of get to review material that you already know. Now, in the case of CPT, you are taking Intro to CPT simultaneously with this course. And so it'll be, a great review. So there are 3 goals that this chapter has for you, or objectives. Number 1, you want to continue to learn the key terms related to ICD-10 coding. You want to describe the use and characteristics of ICD-10-CM and ICD-10-PCS, and then basically know how to use that manual or those manuals. You had these 2 courses, these 2 systems last semester, so I feel like you'll be good to go with this chapter. All right, so you know by now that your ICD-10 CM codes are reported for all diagnoses in all healthcare settings. And in the book, they give you this long list of what is meant by setting, such as hospital, long term care, skilled nursing facilities, all the settings, right? ICD 10 PCS was actually created by the United States for use in the United States. And then CPT and HCPCS are for procedures and services in all other settings. And so it is the opposite of the inpatient, it's the outpatient. So when I look at this first bullet, I kind of just pause for a second to think about what's currently happening at the federal government level, and I'll just explain why. So the ICD-10 system was actually created by the World Health Organization, which is located in Switzerland. And as you should know, ICD 10 CM is the United States version of that ICD 10 system. And it's our version because we added what is known as the clinical modification, which is to classify disease, also known as morbidity. ICD-10, just plain ICD-10 by the World Health Organization, they were looking at death data from death certificates. But here in the US, we use this ICD-10 CM to classify our diseases, right? We are able to communicate to the insurance company what happened to our patient and why. We're able to track different diseases in different areas. So over the weekend, I was watching on the news that there was an increase in respiratory illnesses, and they called out, so they said COVID, respiratory in general. But here's the deal, guys. The way that they know who has what and where is by the diagnoses codes that we assign. Now, of course, keep in mind, it's Super Bowl weekend. And the patients that are seen over the weekend, that data is probably not available to, insurance companies for a couple of weeks, but that's literally how they know that there's a spike in something. So I already mentioned that ICD-10 PCS is only in the US. It was developed for the United States to really provide more specificity regarding the procedures that we do here in the US. Please keep in mind ICD-10 PCS is only for inpatient hospital settings only. And when it was established, the intent was for us to have this multi axial 7 character system that could allow for new procedures when they are invented, because they're inventing new procedures all the time. There are currently about 87,000 ICD-10 PCS codes in the United States. And as you should know, ICD-10-CM and ICD-10 PCS are updated on an annual basis. Now, in the textbook, they actually give you an example of coding manuals that are published by Optum 360. And it just so happens this publisher of our textbook and Optum 360 have some type of collaboration. I can't remember exactly what it is, but that's why those pictures are in there. But keep in mind, on the day of your CCS or CCSP exam, you do have to bring the appropriate manuals. Those happen to be um, options that AHIMA does allow. But please remember, as the person who's taking the exam, it is very important that you go to their website and know exactly what they do require. Because if you show up on a day of the exam without the correct manuals, they will send you away. So different publishers can print ICD-10-CM and ICD-10 PCS. And ICD-10-CM, as you know, is one single manual. ICD-10 PCS is its own single manual. In the textbook, they also talk about the fact that some companies also publish encoders. And this is definitely a term that you want to know as a coder, because an encoder is literally a system, computerized system, that can assign diagnoses and procedure codes. And there are two types of encoders: knowledge based encoders, which means it relies on your knowledge to arrive at the correct code. And then we have logic based encoders, which are coding encoder systems that use code book logic. So, an example of an encoder that is a logic based encoder is 3M. An example of a knowledge-based encoder is nuance clintegrity. And you will have an opportunity to explore both of those encoders later in the program. In addition to encoders, we also have what is known as computer assisted coding, which is designed to help automate the coding process. And the book says, these manuals instead of, or this system, instead of using code manuals, but any coder will tell you that with most of the computer assisted coding, we as coders have to go behind the system and make some corrections to the codes that were assigned. Now, for purposes of the AHIMA exams, you do need to understand what computer assisted coding is. And so basically, what happens is the software uses what is known as natural language processing to read medical records and generate the codes. Now, I know you're thinking, well, is this like Artificial intelligence. So here's the deal, and this is something that a lot of people don't understand. We've had natural language processing for a very long time. Google it, it's a thing, right? So, but what is happening is that this technology is getting better and better. And so, what we see is that the role of the coder is going to shift, where you're going to basically audit the system to make sure that what code was generated is supported by medical record documentation. Okay, because sometimes the computer assisted coding, some people would say a lot of the times, the computer assisted coding, it just makes mistakes. But just like we went from dial up, and some of you may be too young to remember this, we had dial up internet like your phone line at home. And today we are wireless, we have all of this advanced technology, so it will get it right. So, one of the things that I want to tell you as a coding specialist is that it is so very important that you continue to learn and grow. Don't get comfortable. Become comfortable being uncomfortable so that you can continue to grow. In the textbook, they give you a little small demonstration of um, computer assisted coding. All right, so the ICD-10-CM PCS Coordination and Maintenance Committee, they see they oversee the changes and modifications to the system. I think they meet twice a year to talk about changes to the system and what we could potentially see in the future. Oh, and here's that diagram that shows the computer assisted coding process, and I would recommend that you read it because definitely I think it is the CCSP exam where that's one of the tasks under one of the domains that you understand computer assisted coding. So, medical necessity and mandatory reporting of codes. So, the HIPAA law mandated the adoption of standardized code sets. And you probably know this already. There are five HIPAA approved code sets, which is CPT, HICPICS, ICD 10. So that's three. Then current dental terminology, and then five national drug codes. So HIPAA mandated the adoption of these standardized code sets, but it also mandated information that is used to electronically transmit claims. Diagnoses show why something happened today. And what insurance companies are looking for is that why. Was this a medically necessary service to support linking to the CPT code? The concept of linking is something that you will see on the CMS 1500 claim form, which is the claim form that is used to capture professional fee services. And if they discover that that claim is not medically necessary, they could, in fact, reject the claim. All right, so let's talk about the actual manual. So, as you know, there is a single manual for ICD 10 CM. It is divided into two parts: the alphabetical index and the tabular list. The alphabetical index is divided into four parts. You have the index of diseases and injuries, you have the table of neoplasms, the table of drugs and chemicals, and then the index to external causes of diseases. Then the second part, which is where we verify our code, has 22 chapters, and that is our tabular list. The codes that are in the tabular list can have a minimum of 3 characters, a maximum of 7 characters. So, in the alphabetical index, which is where you begin the coding process, you're going to be looking up the actual condition that the patient has. I like to say it's the active thing that's happening to the patient, right? So the textbook talks about how you could use different options, right? An illness, injury, you can use an eponym, which is a disease or a procedure named for a person. You can use abbreviations, but you can also use descriptive terms like acute. Now, the one thing about acute, it doesn't tell you acute what. And so that is a term that I personally try to avoid. So acute or chronic, because those are not necessarily good main terms. I always go to the condition that the patient is experiencing. And so that, and you guys know this from coding already, that main term in the index is bold faced. And that is what is going to be your starting place, right? And then under the main term, you're going to look for a subterm. And sometimes there is a subterm to a subterm, also known as a carryover line. The textbook calls it a qualifier, and they um, break it down into how in depth the terms underneath the main term can go. It is very important to remember that on the day of your CCS or CCSP exam, you will be bringing your coding manuals. As such, it is critical that you take the time now to get to know those manuals so that you're ready on the day of the exam. So here is the table of neoplasms. And as you recall, the table of neoplasms has 6 columns. Those columns identify the type of neoplasm the patient has. So we have our malignant primary, malignant secondary, followed by carcinoma in site 2, which means the cancer is confined to the point of origin. Then we have benign, uncertain behavior, and then unspecified nature. As a reminder, the neoplasm table is part of the alphabetical index, and we can never ever code from the alphabetical index. Then we have our table of drugs and chemicals, which subsequently also has 6 columns. And notice that the first 4 columns are related to poisoning, but different intentions behind the poisoning. And then we have a column for adverse effect and then underdosing. Just like the neoplasm table, we can never ever code from the table of drugs and chemicals. We must always verify the code in the tabular list. Here, what you're looking at is a screenshot of the index to external causes. And you see the index, the alphabetical index, and you see the tabular list. Same concept, you are going to always verify in the tabular list. External cause are basically um, those environmental events, accidents, right, that cause the illness or injury that the patient has. And these codes, the external cause codes, are never listed first. They do not directly impact reimbursement, but reporting them can be helpful to expedite claims when there is an illness or injury that has taken place. So, some basic steps for using the index to diseases and injuries. You're going to, of course, locate that main term, followed by the subterm and the subterm to the subterm, also known as qualifiers. And if you see one or more instructional notes behind the main term, you do whatever it tells you to do. So, for example, if you see condition, that tells you you're not looking up conditions. And so that should be a mental note like, hey, I got to start looking up conditions and not body parts because it keeps telling me to see condition. Of course, like anything else, the more you practice, the easier it becomes. Rule of thumb is we always are going to trust the index in terms of its options that it provides. But when you go over to that tabular list, you don't second guess yourself, but you definitely want to confirm that that code you are going to select is indeed what your patient has. The tabular listing is consisting of 22 chapters based on body system or condition. And in the tabular list, that is when you are going to see lots of instructional notes that are designed to provide additional guidance. And those are going to be things like code first, use additional code, etc. So here is an example from a code book and the tabular list. And one of the things that I would encourage you to do, and this is not something that people realize you need to do, but when you're in the tabular list and you're looking at a code, it is very important to go back to that 3-digit category to see if there are any notes that apply to the entire code family so that you can apply those when applicable. And then here is sample of Z codes in the tabular list. So Z codes are those, what do they call those? They call them factors influencing health status contact with health services. So you may see things like history of neoplasm, but you also may see a diagnosis code to show that a vaccination was given, or that a patient was given a well child exam, or they were getting an adult exam. So, contact with health services as well as health status codes are what you see over in the Z codes. As you should know by now, the guidelines are the key, one of the keys to success with any type of coding. And the official guidelines for coding and reporting are approved, managed, maintained by 4 organizations that are known as the cooperating parties. There are 4 cooperating parties, which are CMS, that's Medicare, the largest payer of healthcare services in the United States, NCHS, which is the National Center for Healthcare Statistics, and then you have the American Hospital Association and the American Health Information Management Association. These guidelines are designed to contain rules that accompany, complement the actual conventions and instructions in the guidelines. And you better believe HIPAA does require that we follow these guidelines when we're assigning diagnoses and or procedure codes. The guidelines themselves are divided into 4 sections and 1 appendix. And as a reminder, if you are coding inpatient, you're going to be using section 1, 2, and 3 of the guidelines. If you're coding outpatient or coding for the physician, you're going to be using sections 1 and 4. Additionally, if you're coding inpatient, and when I say inpatient, I don't mean inpatient for the provider, I mean inpatient for the hospital, you're going to be using also Appendix 1 or I, which is our present on admission reporting guidelines. There are many coding conventions that are discussed in the coding guidelines, and it is very important that you are familiar with those conventions. And as a reminder, we do not um, use any conventions or symbols on the codes. These conventions are basically instructional notes. They're instructing you to do something. And because we have covered this in our intro to diagnosis coding class, I am not going to bore you by going through all of these rules and regulations, because there is a lot of them, and we got 3 chapters. Here are some examples of instructional notes in the tabular list. And remember, I made the comment about going back to the 3-digit category. And so here in this example, we are notified that the appropriate 7th character is to be added to each code from category T36. So here's something that I want to call out. The pink box will tell you which code that particular set of 7 characters should go on. And this is important because you may have more than one pink box in a particular area. So you want to make sure, oh, if I'm using a code that is T36, these are the 7 characters that go with that code. The other thing that is important to call out is how, when appropriate, we need to ensure that if we are using a 7th character, that we have 6 characters that precede it. But I know you guys know that because you've already had intro to diagnosis coding. All right, so lastly here, these are actually guidelines for outpatient coding for diagnosis services. And one of the things that I will just really quickly share with you, when you go to take if you're taking the CCS exam, you have to remember, if you're coding inpatient, follow inpatient rules. If you're coding outpatient, follow outpatient rules. If you are taking the CCSP, where you are only coding for the provider, you want to make sure that you follow those rules. Next, after we get to week 8, you guys are going to be moving on to intermediate coding. And so you will have practice with the 3 types of coding that I just talked about. So, coding inpatient for the hospital, coding outpatient for the hospital, or coding for the physician. You will have definitely practice and will get greater clarity with that type of coding. All right, so lastly, here, definitely make sure you review the key terms that are provided at the beginning of the chapter. Make sure that you know the use and the characteristics of ICD-10-CM and ICD-10-PCS, and then make sure that you know how to use the coding manual properly, as well as apply the guidelines. Now, I know you're probably thinking, this was just a little brief chapter on ICD-10 coding. Please keep in mind that this is the outpatient billing and reimbursement course. And so this particular book is introducing coding primarily for those that are just going to be doing billing, but you are going to be taking the CCS or CCSP. And so you're learning this as a part of your role, the insurance. And so they include the chapters in there. Okay, that's all I wanted to say. I'll be back with part 2, which is chapter 7 on CPT.